关心的是糖尿病的新疗法，可以直接阻断糖分的摄取，可以正常饮食。
糖尿病分为1型糖尿病和2型糖尿病。1型糖尿病病因单纯，治疗药物也是依赖胰岛素注射，但2型糖尿病的病因和治疗方式就比较复杂。
它涉及到那个身体的胰岛素的分泌量不够，它还涉及到那个胰岛素在身体的作用不够好。现在主要是口服药，但是新型的治疗药物有包括注射新的药物，那也有包括我们可以注射胰岛素。
除了注射胰岛素帮助血糖稳定之外，目前更有新型的药物可以阻断身体对糖分的吸收再利用。当我们吃进糖。
Welcome to the Peer-to-Peer Podcast. New perspectives in diabetes, new targets, new therapies, and a new approach to patient management. This activity is sponsored by the France Foundation and is supported by an educational grant from Bristol Myers Squibb and AstraZeneca. Today's discussion, titled When Should We Use SGLT2 Inhibitors, is presented by Dr. John Gurek and Dr. Stephen Whitland. Let's listen in.
My name is Dr. Stephen Whitland. I am a professor in the Department of Medicine at the University of Rochester. My colleague is Dr. John E. Gurek, who is Professor Emeritus in the Department of Medicine at the University of Rochester. Our topic today is going to be, when should we use SGLT2 inhibitors? So firstly, why SGLT2 inhibitors? It turns out that the normal individual clears approximately 180 grams per day of glucose. And that number actually is all absorbed in the proximal tubules of the kidney. Patients with type 2 diabetes actually hyperabsorb glucose so that they may absorb even more glucose, although because of hyperglycemia, there's more glucose in the urine. Therefore, it makes perfect sense to try to inhibit that excessive uptake of glucose as a treatment strategy for type 2 diabetes. Certainly, the majority of patients with type 2 diabetes are not getting to goal with our current therapies, and a therapy that can function such that it does not cause weight gain and in fact might cause weight loss and does not require increased insulin secretion would be a benefit. So it turns out that 90% of the glucose that's absorbed in the proximal tubule is absorbed through a mechanism using a transporter known as the sodium glucose transporter number 2, or SGLT2, which is a lower affinity but high capacity transporter in the proximal tubules, and 90% of the glucose that is in the proximal tubules is resorbed through this mechanism. The 10% that escapes is generally taken up in the so-called S3 segment of the proximal tubule by a sodium glucose transporter called SGLT1. It turns out, therefore, since the bulk of the glucose is absorbed through SGLT2, that it is a reasonable target for inhibition to treat diabetes. Furthermore, because SGLT1 is also found in the gut, it has been shown that nonspecific inhibitors such as fluorescein can induce diarrhea because of blocking the SGLT1. So picking selective SGLT2 inhibitors makes a lot of sense.
I was going to ask you, do these agents do anything else to improve glycemic control? Do they affect beta cell function or insulin sensitivity?
Well, it turns out that directly it's not clear that they do. However, indirectly, because they improve glycemic control, because they do not enhance insulin secretion directly, that they reduce glucose toxicity, that's been demonstrated, they induce weight loss, and therefore enhance both insulin secretion and insulin sensitivity.
Now, there are several agents in development. Only 2 have been approved. Is that correct?
In the United States, canagliflozin has been approved and is on the market. In Europe, dapagliflozin has been approved. Dapagliflozin in particular has a 1,200-fold selectivity for SGLT2 over SGLT1. Cana has about a 200-fold selectivity of SGLT2 over SGLT1. The initial concerns in the United States were, although there were no reports of increased overall cancer with dapagliflozin, that there was a signal for prostate, bladder, and breast cancer, and therefore it was initially not approved in the United States. However, it is currently sitting for FDA approval consideration as we speak.
And there's another one that's been submitted to the FDA, right? Empagliflozin?
Empagliflozin. Empagliflozin also has been studied. It is also an SGLT2 inhibitor that is highly selective. All of these three SGLT2 inhibitors actually have a Cmax at 2 hours. That is to say, they act very quickly. They're all very specific to SGLT2.
Now, where do they stack up in terms of efficacy in lowering HbA1c? There haven't been any head-to-head comparisons within the class, but there have been comparisons between these agents and sulfonylureas and DPP-4 inhibitors. Where do they stack up?
These agents certainly have comparable hemoglobin A1c lowering to DPP-4 inhibitors. They have comparable, perhaps teeny bit less efficacy compared to sulfonylureas or metformin, depending on the study you look at. But certainly there is between a 0.5 and 1% hemoglobin A1c reduction in most of the studies that have been performed using these SGLT2 inhibitors.
Now, because these agents cause loss of calories in the urine, they induce some weight loss. And where do they stand with side effects like hypoglycemia, effects on urinary tract infections or genital tract infections?
Yes. In terms of hypoglycemia, there is minimal to no hypoglycemia that's been reported both in combination with metformin, in combination with DPP-4s, and as monotherapy. In the presence of sulfonylureas, there can be some hypoglycemia, but it's very unusual. And certainly, one would be cautious when using secretagogues or insulin in combination with these, in that the dosage might need to be reduced. As far as urinary tract infections are concerned, there is a small increase in urinary tract infections that has been reported in most of the studies using SGLT2 inhibitors. The major concern along those lines has been more in terms of mycotic vulvovaginal infections, especially, and to some degree balanitis, which has been reported especially in uncircumcised males.
Now, there haven't been any long-term studies of safety on the kidney. Do we worry about adverse effects of this mechanism on kidney function?
There seems to be in patients, especially with moderate renal dysfunction, that there's a mild decrease in calculated glomerular filtration rate based on the formula of EGFR, looking at creatinine levels. But these are clinically small. They're on the order of falls in 3 to 4 ml per minute.
And they're transient, right?
And they are transient. They may, to some degree, be based on fluid fluxes because of the osmotic diuresis that occurs.
Now, there's a hereditary condition, familial glycosuria. Do these people get into kidney problems?
They don't. Just to be more specific, most of the cases of familial glycosuria are due to mutations in SGLT2, and these people do not appear to get hypoglycemic. They do not appear to have really any significant abnormalities, particularly in the heterozygous forms. There are unusual forms, such as mutations of hepatic nuclear factors, where you get other disorders that go along with it, but that does not pertain to SGLT2 inhibitors.
Now, as I recall the ADA guidelines, these agents would seem to stack up very favorably against what we have at present. They unlike your secretagogues, you don't have a risk of hypoglycemia, don't get any weight gain. They have a diuretic action, so you don't get any edema. So far, there have been no bone changes. Where do you think these fit? Right now, everyone pretty much uses metformin as a starter. Where would you place these agents?
Well, certainly, were cost not an issue, I think that these could very, very well be a good second-line therapy after failure for metformin. They, if anything, drop blood pressure a teeny bit. They cause weight loss. They enhance insulin sensitivity by ameliorating glucose toxicity, presumably, and enhance insulin secretion. They, as you said, don't cause bone loss. They don't cause hypoglycemia. They don't cause GI upset, as far as we can see. So they look to be excellent drugs because they appear to be safe and efficacious and do the things that we'd like them to do, as opposed to, for example, sulfonylureas, which, after insulin, are the leading causes of hypoglycemia worldwide.
I see a role for these agents as a potential competitor for prandial insulin. These agents work on both fasting and postprandial levels. And if you have a person on, let's say, metformin and a basal insulin, and they're not achieving their HbA1c goal, it's usually because of not controlling postprandial glucose. So you could use this agent to try and control the postprandial glucose levels and not have to have injections or frequent monitoring of plasma glucose or risk of weight gain and hypoglycemia.
I think that's an excellent point. I think that you absolutely could use them, and in those patients especially who are lean type 2s because they've had it for a long time, in patients who have latent autoimmune diabetes, and that's not an insignificant population of the overall diabetic population. These absolutely could be considered to substitute for insulin, and the good thing about them is that they only really work when the glucose level exceeds the renal threshold.
And they have durability because they don't depend on beta cell function. So as long as you maintain renal function, these agents should be continuously effective.
That makes perfect sense to me.
This concludes the discussion. We would like to thank Drs. Gurick and Whitland for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.t2diabetescme.org.